Last but certainly not least, we've got a presentation from Gleb Levitsky titled Quality of Care and Adherence in ALS in Russia.
Good day, ladies and gentlemen. My name is Gleb Levitsky. I'm director of Nina Levitsky Russian Charity ALS Foundation. I would like to speak about our study of quality of care and compliance in Russian ALS patients. We studied 63 pulse in state ambulatory number 144, including 7 follow-ups, and 36 pulse examined in Real Health private clinic, including 9 follow-ups. 153 documents of pulse were assessed, including 28 follow-ups in Russian Charity ALS Foundation. In total, we studied 251 pulse within age range 21 to 77 years, 134 males and 117 females. 178 spinal onsets, 70%, and 73 bulbar onsets, 30%. Elastorial diagnostic criteria were used, that is, materials and methods. So what were the criteria of high quality of care for pulse? Diagnosis by Elastorial criteria 1998, within a year since disease onset. Description of neurological status in documents of pulse. Presence of needle electromyography, spirometry and diagnostic protocol, presenting information to pulse about information about riluzole, non-invasive ventilation, gastrostomy, artificial ventilation, registration of any disability group for pulse, and prescription of myorelaxants, which are included in free register of medication for disabled people in Russia. What were the criteria of high compliance of pulse? For document consultation, it were filling of clinical scales for pulse in electronic form for 1 time in 3 months, 2 to 3 times. For eye-to-eye consultations, it were follow-up consultations 1 time in 3 months and repeated consultation by telephone with detailed description of complaints and filling of clinical scales in electronic form 1 time in 3 months, and fulfillment of international standard of ALS management by patient, such as riluzole, non-invasive ventilation, gastrostomy, and sometimes invasive ventilation. So what were the results by quality of care? Here we see the variation curve. We saw negative events less than in 12% of cases. There were steroid use, no neurological status, injections in atrophied muscles, vertebral surgery, no needle AMG, concealing of diagnosis, formulation of diagnosis as ALS syndrome. More than in 95%, we saw neutral events, such as vocalizing the diagnosis of ALS, needle electromyography, and vitamins and physiotherapy. And less than in 7% of cases, we saw positive events, such as gastrostomy, riluzole, non-invasive ventilation, tracheostomy, and invasive ventilation. So neither patients nor doctors in Russia regard palliative care important. Results considering compliance of pulse. Filling of clinical scales 1 time took place in 28% of cases. 1 time a year in 10 times, 9% of cases. Follow-up consultations in ambulatory 1 time in 3 months took place in 7 cases, 11%. Follow-up consultations in private clinic 1 time in 3 months took place in 9 cases, 25%. It was P less than 0.05. Repeated consultations by telephone in the foundation took place in 33 cases, 7%, and repeated consultations by telephone in the private clinic took place in 25 cases, 33%. So it was statistically more significant than in the foundation. A single or repeated appointment of PALS to medical institutions or persons with no international standard of ALS management acceptance was seen in 200 cases and 21 cases respectively, so 79% and 8%. That was the results of compliance of PALS. So what is the discussion? So 200 PALS received low quality of care and it was characterized but low compliance, single visits. Only 30 PALS, only 12% of PALS received care with the international standard with high level of compliance. Neither doctors nor patients in the majority of cases regard palliative care important. Problems to achieve high quality of care are insufficient information about ALS, low motivation of medical personnel, financial limitations of medical and social aids in ALS, and absence of medical standard of multidisciplinary care in ALS in Russia. Problems in compliance are high morbidity of anxiety and depression among patients and relatives, aiming to receive information about the disease from unreliable sources, low motivation for follow-up due to fatal character of the disease, and also time and infrastructural and administrative limitations of the healthcare system, low confidence to specialists. Evidently, the system of care of patients with fatal disease, which is exceptionally free of charge or exceptionally chargeable, is ineffective. The most effective is the system in which services of insurance medicine, private clinic, charity aids, and social support are combined, and in which different means of interaction between customer and representative of services are maintained. Thank you very much.
Thank you so much, Gleb. I'm not sure if Gleb is on the call today. Are you there? We couldn't see him through the technical team. Possibly not. In which case, it might be nice to capture the questions anyway. So please do use the chat, and we'll make sure that we can get questions to Gleb after this session. Unless he is there. No, I don't think he is. No. Okay. So I think that's probably time to wrap up then. Thank you everybody for taking part today. Now we will move on to some small group discussions again. As a reminder from last time, to access this, you must select back to timeline on the top left corner of your screen. This will take you back to your timeline where you must select group discussions to enter the discussion group as you did before. And this networking tool will continue to be open until 11:15 Eastern Standard Time. Thank you for having me as moderator today. I thoroughly enjoyed it and learnt an awful lot. And join us back here tomorrow at 7 AM Eastern Standard Time for the continuation of the Alliance meeting. Thanks so much.